Good afternoon, and welcome to this webinar on the impact of COVID-19 on fracture liaison services, how to maintain and resume patient care after the pandemic. Please do not hesitate to ask your questions during the webinar by typing your questions into the question box on the control panel to the right of your screen. The questions will be voiced to the speaker towards the end of the webinar. Thank you in advance for your participation. My name is Eric Bredet-Champagne. I'm the Capture the Fracture Coordinator at the International Osteoporosis Foundation, and I will be the moderator for today's session. Before introducing our speaker, Professor Thierry Chevalet, I would like to inform you that all participants are automatically muted for the duration of the webinar. And with that being said, I will now introduce briefly our speaker for today, Professor Thierry Chevalet. So Professor Thierry Chevalet is Associate Professor of Medicine at the University of Geneva in Switzerland. He is head of the Geriatric Liaison Service in the Rehabilitation and Geriatrics Department and consulting physician in the Division of Bone Diseases at the Geneva University Hospitals. In addition to his involvement in pre- and postgraduate medical education, his research work concerns comprehensive geriatric assessment, fracture epidemiology, secondary prevention of osteoporosis, for example, in fracture liaison services, and the influence of genetic and environmental factors on bone microstructure. He is a member of the Committee of Scientific Advisors of the IOF and of the Scientific Committee of SKO. He is a reviewer and a member of the editorial board of several scientific journals in the geriatrics and bone field. With that said, I will now leave the floor to Professor Thierry Chevalet.
Thank you, Eric, for this introduction. It's a great pleasure to be there and sharing with you this topic on the impact of COVID-19 on fracture liaison service. I have no disclosure. During my presentation, I will address the following points. First, the impact of COVID-19 pandemic on osteoporosis in patients with fragility fractures. Then we'll discuss how do we address the increasing backlog of patients, and then how to manage patients in orthopedic centers in the absence of DXA availability, and finally, how to manage anti-osteoporotic treatment initiation and follow-up with COVID-19 pandemic. At first, how was COVID-19 affected the treatment of osteoporosis? Together, IOF and the National Osteoporosis Foundation have performed a global survey on its impact on osteoporosis management through questionnaires. About 200 healthcare workers responded from many countries, from different continents, with a majority of physicians, especially rheumatologists and endocrinologists, as well as physical therapists and nurses. And the survey showed that 33% of the consultations were performed by telephone and 21% by video, but only 29% were able to obtain a DXA scan as recommended. 60% of the healthcare workers had systems to identify patients receiving parenteral medications. And finally, 43% reported difficulty in arranging appropriate osteoporosis medication. Another recent survey, on the next slide, performed in the Netherlands, was based on 17 questions sent to physicians, nurses, and physician assistants. And the survey has shown almost similar results, with a decrease of 51% of DXA scanning and the absence of DXA for 47% of them. There was also a huge increase of video consultations for new and control visits, a decrease of 57% of the quality of care regarding fracture prevention, and a delay in the administration of anti-osteoporotic medication, respectively 45% for IV bisphosphonate and 6% for Neurozumab. On the next slide, another survey was performed by NOF in May 2020 on the patient perspective. Among almost 350 responses of patients, mainly osteoporotic and aged 65 years and over, treated mainly by primary care physician or endocrinologist, 40% of them reported that their provider's office was open for osteoporosis care, but only 18% of them attended an in-person visit. Furthermore, 28% either canceled or rescheduled an appointment with their bone health provider for the different reasons mentioned on the graph at the bottom of the slide. Now, on the next slide, what was the global impact of COVID-19 on the online access to FLS? This is a retrospective analysis which was performed on daily sessions on the FLS website before and after the declaration of the pandemic, and according to the geographical source of that activity. You can see that the number of sessions fell by 23% and 58% respectively in March and April 2020. We observed also that there was a greater range of percentage decrease between continents in March as compared to April, with a decrease of almost 50 to 60%, except for Asia. Now, what about bone mineral density measurements? Regarding bone density measurements, they were not easily feasible due to the lockdown, with many DXA services deprioritized or paused. Therefore, in June 2020, as compared to 2019, it was estimated that 73% fewer DXA scans were performed across the UK, underlining that it will take many months before the backlog is cleared and waiting lists return to acceptable levels. This emphasizes also the greater dependence on clinical history, especially any previous fracture, as well as the use of fracture prediction tools. Now, on the next slide, you can see that adherence to parenteral osteoporosis was also poor during the COVID-19 pandemic. As reported in this study performed in Austria, based on field prescriptions for denosumab and zoledronic acid from January 2017 until September 2020, the results showed a continuous increase of DMAB prescriptions over the last 2 years, with a remarkable decrease only during the first COVID lockdown in March and April 2020, with a respective reduction of 22 and 23% as compared with the 6 months prior. And for the zoledronate, we observed also a significantly lower prescription in the 2 months, during the 2 months of the first lockdown, as compared with the 12 months prior, with a decrease of respectively 36% and 49% in March and April. Now on the next slide, did the COVID-19 pandemic affect the incidence of fracture? In the study performed in Poland, among inhabitants older than 50 years of age, the incidence of forearm and hip fractures occurring during 77 days from March 16 to May 31, 2020, were compared to the incidence of these fractures during 77 days in years 2015 to 2019. And you can see on the table that we observed a decrease of the incidence of 46% for the arm fractures, 18% for forearm, and 13% for the hip fractures. And by extrapolation for the whole country, this would correspond to many avoided fractures at these different skeletal sites. Now, how do we address the increasing backlog of patients? On the next slide, you can see that during the COVID, many FLS, including the associated rehabilitation services, have largely closed. Therefore, we observed a decrease of outpatients with non-hip fragility fractures to the fracture clinic. We observed also a delay to surgery, which was reported in some studies related to COVID admissions. And due to the redeployment of staff, there was a decrease of the management by the orthogeriatric team for hip fractures. Since physiotherapists in acute services were recruited, no adequate care were delivered following discharge of hip fracture. And finally, a lower prescription for either calcium vitamin D supplements and osteoporosis medication were observed, with a possible impact on fracture burden. Now, since FLS and osteoporosis outpatients were on pause, one approach to overcome these difficulties was to use telemedicine. In fact, you know that use of telemedicine for osteoporosis exists already in large countries such as Australia and Canada. Furthermore, telephone consultations in FLS were also previously used in the UK to improve adherence to anti-osteoporosis medication. According to a recent study in the UK, video or telephone consultations are popular among patients and shorter than face-to-face. But it was also reported that they had a slower score on some quality measures, such as seeking patients' understanding of their health problem. And it was also recently reported in a review that video and telephone consultations were associated with fewer medications errors and greater diagnostic accuracy. Therefore, on the next slide, one approach was to create a virtual fracture liaison clinics as an alternative to face-to-face clinics during the COVID lockdown, with the DXA services closed. As reported in the study, patients were assessed with a structured telephone clinic appointment, which included fracture risk and health promotion assessment, as well as a treatment plan. The mean fracs for major orthopedic fracture was 18% and 7% for hip fracture. We observed a high attendance rates of almost 80%. However, a significant number were still not available, and 10% of them canceled the appointment. A recommendation for bisphosphonate treatment was made in 54% of them, of the cohort, based on NOG criteria, and follow-up DXA assessment was planned for 64% according to fracture risk and NOG. 50 patients at DXA, and in 62% of them, there was a concordance between virtual FLS recommendation and the subsequent outcome after DXA. And in 9 out of 19 cases, a recommendation made to start bisphosphonate after DXA. And regarding the 60 responses to the initial patient survey, it was interesting to note that 90% of them rated their experience as very good to excellent, and 98% of them will indicate they would recommend the services to others. Nevertheless, there are some limitations with virtual telephone FLS assessment. In fact, it's not ideally adapted to assess clinical factors, but more on clinical history, and for patients with hearing loss or cognitive impairment. It is also unclear whether video rather than telephone consultations offers any advantage to clinicians. And finally, a significant proportion of the FLS caseload still requires DXA follow-up to complete the clinical assessment, as we have shown previously in the last study. Now, how to manage patients in orthopedic center in the absence of DXA availability. It's important to encourage simplified procedures in FLS centers. For example, we can keep a list of patients with fragility fractures to perform further evaluation, ideally within 6 months. It's also possible to establish pathway in the orthopedic centers in order to initiate appropriate osteoporosis therapy to eligible patients over 65 years. It's important to do it before discharge for patients with a major fragility fracture, hips, spine, humerus, and pelvis, without a DXA scan and in the absence of contraindication. And of course, it is of great importance to reopen the DXA VFA access as soon as possible. Now, to avoid hospitals and doctor's office, and since it is critical to stay fracture-free, some recommendations need to be mentioned to patients, such as ensure that home environment is fracture-free for fall prevention. Important that patients should not discontinue any osteoporosis treatment, including calcium and vitamin D supplements, and should try to arrange a telephone appointment and avoid social isolation, and also could ask for support either for shopping or for prescriptions. Now, to avoid too long waiting lists for DXA, a rapid, simple, and pragmatic one-stop algorithm was developed using UK guidelines to triage DXA testing, incorporating medication use, aromatase inhibitor, and corticosteroid, and clinical risk stratification using FRAX to produce a recommendation to either treat empirically high-risk patients, to perform a DXA for intermediate risk, or to observe with a patient with low risk. It was estimated that this will reduce DXA scan numbers by about 50%, while pragmatically ensuring those with the highest risk need correctively will receive treatment without delay. Now, I have to mention that this pragmatic approach uses UK guidelines as an example, but this approach is flexible and could be adapted by other countries based on their local guidelines and DXA waiting list times. Now, what about anti-osteoporotic treatment initiation? Initiation of osteoporosis therapy can be done in outpatient by telephone or video, and an oral treatment can be easily introduced. And particularly, initiation of therapy is very important for patients at high risk of fracture, especially those with a recent fragility fracture or those with chronic high-dose glucocorticoid. And in patients with fractures requiring hospital admissions, it is very important to initiate anti-osteoporosis medication during hospitalization. And this is very important to avoid lost follow-up in the post-discharge period. And it is also very important to continue to receive the ongoing therapies listed in this slide. Now, are there some precautions to take into account in the FLS centers before initiating anti-osteoporosis medication? In fact, normal adjusted serum calcium and a serum level of 25 hydroxyvitamin D equal or above 15 nanomole per liter is required to introduce bisphosphonate, DMAP, and teriparatide. And during inpatient stay, ZOL or DMAP with calcium and vitamin D can be considered, but with some precautions. You know that ZOL is contraindicated with creatine clearance below 35. And what is important that ZOL can be introduced within 2 weeks of a hip fracture if the patient is eligible, because it was described that there is no evidence for impaired fracture healing. It's important to know that ZOL can be postponed in most circumstances. And for DMAP, there is a caution with a creatine clearance below 30 ml per minute, or for those receiving dialysis with a high risk of severe hypocalcemia. And it's important to know that for DMAP, the next injection do not be delayed for more than 4 weeks. And as alternatives, you can use oral bisphosphonate, either alendronate or risedronate. In summary, next slide, for the treatment with parenteral osteoporosis therapies, if we consider anti-resorptive therapies, for zoledronate, the treatment can be delayed for 6 to 9 months. And if the delay is longer, the transition with oral bisphosphonate is possible. For denosumab, the treatment needs to continue due to the risk of rebound, bone loss, and fractures. And if it is not possible, despite alternative methods of delivering parenteral osteoporosis treatment, a transition to oral bisphosphonate is possible with a clearance above 30 milliliter. What is also important is to give a bolus of 25 to 50,000 units of vitamin D on the day of injection, and the serum calcium and renal function may be checked in those with fluctuating renal function. And for anabolic agents, teriparatide or Neurozumab should be continued or consider a transition with oral bisphosphonate if stopped more than 3 months. Now, what about the relationship between vaccination for COVID-19 and osteoporosis? So far, there is no evidence that any osteoporosis therapy increase either the risk or severity of COVID-19 infections and or interferes with the efficacy or side effect profile of COVID-19 vaccination. Therefore, IV bisphosphonate can be introduced 1 week after vaccination to distinguish putative acute phase. And in case of previous zoledronate treatment, subsequent infusions may be delayed for up to several months. For denosumab, it can be introduced at a 4 to 7 days interval, but should not be given later than 7 months after the last dose. And for teri and abaloparatide, should be continued in patients undergoing vaccination, and for Neurozumab may be given at an interval of 4 to 7 days with the COVID vaccine. Now, regarding the management of fragility non-hip fractures, for distal radius, vertebral or proximal humerus fractures, it's important if they should be managed conservatively, it's much better. Now, telemedicine, whenever possible, for follow-up, including modifiable risk factors. And the role of physiotherapy should be properly explained, since immobility due to the lockdown is a challenge for many patients. And to recommend low or high impact aerobic activity, indoor walk or muscle strengthening and balance exercise is also very important to consider for these patients. Now, regarding the management of hip fracture, a multidisciplinary approach remains the key in management, as you all know. Now, it's also important to introduce some quality improvement programs, and it was done among junior doctors and nurse practitioners who were able to increase the prescription of calcium, vitamin D, bone sparing drugs, and DEXA scan. As you can see on the next slide, it's possible to improve secondary prevention of hip fractures using a quality improvement program. In this study, a retrospective audit was conducted before and after the lockdown in response to the pandemic in the UK, and the re-audit was conducted following the development of a new mnemonic tool to improve junior doctor, advanced nurse practitioner, and medical student awareness of secondary fragility fractures preventions, with the many items that are mentioned on the right part of the slide: medication review, blood test, DEXA scan, orthopedic review, nutrition, exercise, supplements of calcium, vitamin D. And as you can see on the table, the lockdown was associated with a significant drop in the prescription of vitamin D and calcium from 82% to 58%, but it was also associated with a decrease of bone sparing medication from 61% to 18%, and from DEXA request from 14% to 4%. After intervention, there was a significant increase in the prescription of calcium and vitamin D supplements to 86%, to bone sparing medication to 72%, and to the DEXA scan to 60%. And therefore, we can see that this quality intervention significantly improved management and could be used in a wider setting. In addition, on the next slide, access to rehabilitation should be available for hip fracture patients. This requires social distancing and infection control. And accelerated care pathway should also be organized for hip fracture patients with COVID due to their high mortality, in order to reduce the length of stay and requirement for intensive care bed. And it's also important to review chest X-ray and CT scan for identification of prevalent vertebral fractures, and to use appropriate management in these patients. Finally, on the last slide, you can see that the secondary prevention of fragility fractures is strongly recommended and of particular importance during and after the COVID-19 pandemic. Indeed, inflammation, immobilization, hospitalization, and home isolation may induce bone and muscle loss, and therefore increase falls, fractures, and death. Therefore, for patients with a previous fracture, they must be informed that they are at increased risk of subsequent fractures, especially over the next 1 to 2 years, and to reduce their risk factors. Risk assessment for falls should also be performed, and anti-osteoporotic treatments should be initiated or pursued in the hospital with a regular follow-up and referral, which can be performed by video or telephone consultation. And in addition, we should not forget to maintain optimal vitamin D levels will support bone and muscle health, especially in elderly patients. I thank you for your attention, and I will take your question. Thank you very much.
Thank you very much, Professor Chevalet, for this excellent presentation. So now we are entering the question and answer period for today's session. I'll give you a few moments to think of your questions, write them down in the question box, and we'll begin to answer the questions very shortly. Okay, we have the very first question to start off. Do you have experiences regarding the Neurozumab medication, if any?
We started to use Neurozumab just a few months ago, and we can say that so far we were not very successful in the way that many insurances do not allow us to use it. They always try to convince us to use other treatments, which are less expensive, of course. I don't know how it is in your countries.
Excellent. Another question, how has the COVID-19 pandemic impacted your management of patients at the Geneva University hospitals?
Yes, that's very important. We have looked at our activity and compared our activity, our FLS activity, between 2020 as compared to 2019. And we were able to see that our activity has decreased by about 31%. And we also looked at the numbers of DEXA which were performed at our university hospital, and there was also a decrease of 32%. And of course, this decrease was it's 31% or 32% decrease over the whole year of 2020, because as you know, there were 2 or 3 waves, and the DEXA scan availability was not available at least 2 or 3 times in the year. So it was a huge decrease of the activity during the pandemic at the Geneva University Hospital.
Thank you, Professor Chevalet. We have another question here. So will the COVID-19 pandemic affect the cost effectiveness of fracture liaison services?
Yeah, it's possible. I do not have so far the data. What we have seen that I'll show you a study. We have shown that during the first months of the pandemic, there was a decrease of the incidence of some kind of fractures. But it could be that this decrease was very temporary, and that it could be followed by a further increase of these fractures. And I am not sure that I can say that during the pandemic, it was more easy to treat maybe some hospitalized patients than some outpatients. And because it was more difficult to have the list of these patients sometimes and to join them and to convince them. So it could be that the cost effectiveness will be affected, but I have not the data for that.
Thank you for the response. So another question is here, what are the pros and cons of going back in time post-COVID to find missed patients versus just going forward with new patients that come in?
Yes, this is a very tricky question because, of course, as you have said, we are back. We have a backlog of about 30% of the patients for the 2020, and so now it's a challenge. What I can say, what is very important, is to think of the patient with a higher risk of fractures, and for that, I think we have to select a little bit at first, the first time, the patients for whom we think they are most used to be treated. And because I'm not sure that we will be able to recover all the patients. But what is important is to track all the patients now we are including in the FLS now in 2021, and to try to reach all the previous patients that we lost according to the risk that we can evaluate it very with a few information.
Okay, thank you. Another question, have you noticed any differences in the patient acceptance or compliance of treatment recommendations when using these simplified procedures as you've described in your presentation?
I do not have the data, it's more an impression. Of course, you know that what is very important, it's the role of the practitioner, of the primary care physician. And during the pandemic, not only physicians working at the hospital had some difficulties to reach the patients and to initiate the treatments, but also the follow-up of these patients was not so easy for the primary care physicians. So I cannot exclude that not the acceptance, but more the compliance of the treatment, because we know that what is very important is the first 3 months after the initiation of the treatment, that the role of the primary care physicians, it's very important that to assume that the patient will continue the treatment.
Okay, thank you. Okay, another question is, do you have any examples of best practices for conducting telehealth consultations, so virtual consultations?
Yes. No, what I can say, it's at least it was for me, and I think for many physicians, quite a new way of have a contact with the patient and to treat patients. And of course, what is very important, it's because it was not only new for the physicians, but it was also new for the patients. And some patients were very stressed to have this kind of telemedicine. And I think we have to be very empathic with these patients, and it takes sometimes, could with some patients take more times to cool them down, cool the stress, and explain them why it's very important to have this conversation and why it is important to take care of their bone and things like that. So I think that it's very dependent of the patient. Some patients are very, it's a very easy way to communicate because they are using the video and things like that every day. So the work of it. And in this case, it's quite easy. For some other patients, it could be also some patients who have some hearing problems. And for this case, we have to take the time to convince them, and if we want that they will initiate and pursue the treatment.
Excellent. Thank you, Professor Chevalier. So we'll have just a few more moments if there are any other questions. We'll take one or two last questions now, and if not, we will close the presentation shortly. Excellent. Okay, thank you very much. So on behalf of IOF, I would like to thank you for your participation to this webinar, and I hope you enjoyed this session. We will publish the recording of this webinar on the IOF website, as well as the Capture the Fracture Resource Center, and you will receive the link by email at the beginning of next week. You will be prompted to complete a brief survey immediately after this webinar. We'd appreciate your input and your comments as we continuously try to deliver webinars that meet your demands. And if you have any questions or comments, please don't hesitate to contact us by email at webinar@iofbonehealth.org. With that, I would like to thank you again, Professor Thierry, for once more for this outstanding presentation, and I would like to thank all the participants for joining the webinar. With that, I wish everybody a pleasant rest of the afternoon, morning, and evening ahead. Thank you, everybody.
Thank you very much. Bye-bye.
Bye.